Hi, myself Dr. Monica Mehnoth. Today we will discuss about classification of dental caries. First, it is classified according to the location. The caries lesion varies with the nature of surface on which the lesion develops. It is divided into primary and secondary caries. The primary is the original caries lesion on the tooth. There are three morphologic types in primary caries: patent fissure, smooth surface, and root surface caries. The patent fissure caries are the most susceptible surface for caries initiation, as it provides the mechanical shelter for the organism to harbor. These are patent fissure caries. Now, how is the progression of caries in patent fissure? The initial lesion will develop on the lateral walls of patent fissure. This is patent fissure. These are the lateral walls. The caries will initiate in the lateral walls of patent fissure. The demineralization follows the direction of enamel rods as it approaches dentino-enamel junction. Means as the caries penetrate the enamel, it will grow laterally, approaching our dentino-enamel junction. This is dentino-enamel junction. The caries will spread laterally, approaching towards dentino-enamel junction. As this initial lesion will occur, there will be a reaction seen in dentine and pulp. So this will approach enamel, dentine and then pulp. Suppose there can be one more case if the enamel starts remineralization process. For example, the fluoride content in our saliva starts remineralization process of this occlusal surface. Then the entry point of this carious lesion, deep cavity, will get narrower, which is difficult to detect clinically. But the deep caries activity of the dentine will be means the shadow of this deep cavity will be seen on the enamel surface. Now the smooth surface caries. These are the second most susceptible areas for dental caries. For example, the proximal surface area gingivally beneath the contact point are the most susceptible area. Because of the contact point, it is protected physically and also are free from the microorganisms and effect of mastication, tongue movement and saliva. The type and number of microorganisms in the biofilm also vary depending on the topography of the tooth surface and size and shape of gingival papilla and oral hygiene of the patient. Now the smooth surface caries. These are the second most susceptible areas for dental caries. For example, the proximal surface area gingivally beneath the contact point are the most susceptible area. Because of the contact point, it is protected physically and also are free from the microorganisms and effect of mastication, tongue movement and saliva. The type and number of microorganisms in the biofilm also vary depending on the topography of the tooth surface and size and shape of gingival papilla and oral hygiene of the patient. The rough surface restricts adequate biofilm removal and favors occurrence of caries and periodontal disease. The smooth surface have broad surface area of origin and a narrow and conical point towards the DEJ. Totally opposite of the patent fissure caries. As you can see here, the area of origin is broader and as it approaches the DEJ and towards the dentine, it is narrower and conical in shape. As you have seen in patent fissure caries, the area of entry is narrower but towards DEJ it gets broader. In cross section, the smooth surface caries also shows V shape. Root surface caries. It is mostly seen in older people because of the factors such as decreased salivary flow, poor oral hygiene and decreased motivation. It is seen in the proximal, facial and lingual root surface, particularly near the cemento-enamel junction. As you can see here, it is enamel and cementum junction, which is CEJ. The root caries are more prone in this area because it is unaffected by the oral hygiene procedures such as brushing and flossing, which it On addition, when this cementum is exposed to oral environment, such as in case of gingival recession, it is more prone to dental caries because the cementum is less resistant than enamel to dental caries. The root caries are alarming because the cementum are less less resistant to dental caries, and the progression of dental caries are very rapid. It is often asymptomatic, it is close to the pulp, and it is very difficult to restore also. According to extent, it is classified into incipient caries and cavitated caries. Incipient caries are also called as white spot lesions, which is reversible in nature, and cavitated caries are irreversible in nature. You may have seen in persons whose mouth are dehydrated, there are small white spots on the tooth surface, which gets disappeared when the person drinks liquid or water. So they are white spot lesions. Its appearance is opaque. When air dried, it disappears when it gets wet. The incipient caries are the first evidence of caries activity in enamel. Its clinical features are it is hard, intact, and smooth in nature to touch. On the contrary, the cavitated lesions are broken because the caries are advanced into the dentine. According to rate, it is classified into acute and chronic. Acute is also termed as rampant caries. It is a disease that rapidly damages the tooth, means the demineralization process occurs very rapidly. It is soft, light in color, and is infectious. It is soft, light color, and infectious because it is growing too rapidly, and light color because the extrinsic pigmentation takes less time. Now the chronic or slow and the arrested after a severe active phase because of the process of remineralization. The caries process progress from acute to chronic phase because of the process of remineralization. As a result, it caused the surface which is intact, hard, and discolored. As a result, the arrested caries are brown to black in color. This dentine is termed as eburnated dentine, as it is open, hard, and discolored. Now, according to histology and depth, it is divided into enamel and dentinal caries. In enamel caries, it is classified into non-cavitated and cavitated lesions. The non-cavitated lesions are the white spot lesion, as we have read earlier, and cavitated lesions are when the caries approach enamel with a cavity, and then it advances into the dentinal caries when the caries approaches dentine. Now about zones of enamel caries. There are 4 zones: translucent zone, dark zone, body of lesion, and surface zones. You can remember it as TDBS, trained dentist better stipend. First we will talk about surface zone. It is the outermost layer of enamel. As you can see here, the black line you can see is the surface zone. It is almost normal, intact, even in early decay because it is unaffected by the carious attack. It is intact surface over incipient caries. It is hypothesized as hypermineralization and of fluoride content. It is a thin protective layer that hasn't broken yet. Now about zones of enamel caries. There are 4 zones: translucent zone, dark zone, body of lesion, and surface zones. You can remember it as TDBS, trained dentist better stipend. First we will talk about surface zone. It is the outermost layer of enamel. As you can see here, the black line you can see is the surface zone. It is almost normal, intact, even in early decay because it is unaffected by the carious attack. It is intact surface over incipient caries. It is hypothesized as hypermineralization and of fluoride content. It is a thin protective layer that hasn't broken yet. Now the second one is body of lesion. It is the largest zone because of demineralization phase. As you can see here, the body of lesion marked by blue. It is the main damaged area under the surface with the maximum mineral loss happens here. It is like the core of cavity forming underneath. It is the main area where the caries activity happens. Then the third one is dark zone. It is the second deepest area. It cannot transmit polarized light because of the small pore size. It is the phase of remineralization and demineralization. Therefore, it is less in area. It is the dark zone. Then the final one is the translucent zone. It is the deepest advancing zone which has the pore size of 1% forming along the enamel rod. If the pores are filled with quinolone solution, it gets disappeared because the refractive index of enamel and quinolone solution is the same. So we have noted like the outermost portion is surface zone, then the body of lesion, then the third one is dark zone, and the fourth one is translucent zone, where the surface looks better and the body has the most damaged area, with the dark zone trying to heal and the translucent zone where it starts. Now about zones of dentinal caries. There are three zones: infected dentin, affected dentin and normal dentin. Affected dentin is the outermost part of the carious lesion. In affected dentin is beneath it. It is the inner part of the carious lesion. And normal dentin is normal. The infected dentin is infected. The affected dentin is unaffected. The affected dentin is remineralizable while the infected dentin is not remineralizable. The infected dentin is not sensitive, but the affected dentin is sensitive. The infected dentin contains bacteria, but the affected dentin does not contain bacteria. Therefore, it is essential to remove it. The infected dentin is soft in nature, but the affected dentin is hard in nature. In infected dentin, collagen is denatured irreversibly, but in affected dentin, the collagen cross-linking is intact. That's why it has a self-repairing action. But the infected dentin cannot be self-repaired. The infected dentin should be removed. It should be always be removed by hand or instruments. But the affected dentin should be preserved because we are approaching for conservative treatment. As you can see in this picture, the red portion here is the infected dentin and the green part here is the affected dentin beneath your infected dentin. So the infected dentin part should always be removed, but the affected dentin can be preserved for conservative approach. Now the mechanism of remineralization process of white spot lesion. What is white spot lesion? It is an initial caries lesion which can be remineralized. So the process of remineralization as follows. The saliva becomes supersaturated with calcium and phosphorus ions which act as a driving force for remineralization process. Means the saliva here became the source for calcium and phosphorus ions. And the enamel in non-cavitated lesion, the enamel crystals act as scaffold for the deposition of this calcium and phosphorus ions. Means the enamel rod and hydroxyapatite crystals are preserved which act as a scaffold for these ions to get deposited. It also acts as a nucleating agents for this ion to deposit. When the calcium and phosphorus ions enters lesion, it replaces the lost minerals which gets dissolved by the acid attack. How the role of fluoride is helpful in process of remineralization? As the fluoride, trace amounts of fluoride present in our oral cavity, it will act on calcium and phosphorus ions, means it will get combined with these ions and make fluoroapatite crystal which is more resistant to acid attack, which will make the lesion arrested. Now the caries which are incipient caries now became arrested, which is brown and black in color. It gets hard and smooth, which is resistant for future caries lesion. If you like my video, please like, share and subscribe.